Good afternoon, everyone. Welcome to the latest talk in the CADTH lecture series. I'm Michelle Mujumdar, Director of Scientific Affairs at CADTH, and I'll be moderating today's session. I'd like to start by acknowledging that today's talk is being presented on the traditional and unceded territory of the Algonquin Nation. We launched the CADTH lecture series 6 years ago so people from across the country and abroad could hear directly from prominent scholars and opinion leaders about pressing areas in health technology assessment and healthcare today. Today's lecture will discuss the various hypes, spins, conflicts, and potential biases affecting the practice of oncology and provide recommendations on how to control or correct these issues. While the focus is oncology, the key points are applicable really to any disciplines of medicine. After the lecture, we'll open things up for discussion and questions from our in-person audience here in Ottawa, but also our online audience. It should be quite a discussion because we have more than 550 registrants for today's talk. So I'd like to introduce my colleague, Dr. Amy Sood, Manager of CADTH Scientific Advice Program, who's going to be helping me moderate questions. So if you see us kind of chatting to each other, that's really what we're trying to do. Online participants can enter their questions at any time through the live stream platform. And this is a Twitter-friendly event, so we'd like to encourage you, both online and in person, to tweet and follow tweets during the lecture. And we'll be using the hashtag CADTH Talks, which is here on the screen. And that provides a really appropriate segue to my introduction of today's speaker, Dr. Bishal Gyawali. Because I first encountered him through his frequent, but not too frequent, tweets. I would say that his tweets are always thoughtful and insightful. Dr. Gyawali's Twitter handle is @oncology_BG and is certainly worth a follow. He's a medical oncologist with extensive international experience in cancer care, including from Nepal, Japan, Belgium, the United States, and now Canada. So we're delighted that Dr. Gyawali now calls Canada home. He's joined the talented people at Queen's University in Kingston, Ontario as assistant professor in the Department of Public Health Sciences and as assistant professor in the Department scientist in the Division of Cancer Care and Epidemiology, and a clinical fellow in the Medical Oncology Department. He is also an affiliated faculty at the Program on Regulation, Therapeutics, and Law in the Department of Medicine at Brigham and Women's Hospital in Boston. Some of you may have heard of the Cancer Moonshot Initiative that was proposed a couple of years ago. Well, Dr. Gyawali coined the term cancer groundshot to imply that investment should be made on proven high-value interventions in cancer care that are easily implementable globally and are affordable. So I think his talk will be of great interest to many people. So please give a warm welcome to Dr. Bishal Gyawali.
Thank you very much, Michelle, for the kind introduction, and thank you, CADTH, for this wonderful opportunity to share some of my thoughts here today. Actually, this is my first lecture talk in Canada after I moved to Canada a few months ago. So I'm especially honored to be here today, and thank you very much for the invitation. So the title for my talk is Why Oncology Needs More Common Sense and Less Cheerleading. And actually, to be honest, I have found that common sense prevails in the Canadian oncology community more than what I have found in other countries. Let's discuss about some of the issues that I find to be problematic in the field of oncology and what we can do about it. First of all, my disclosures, I have none. And I need to say that I'll be citing a number of examples of bad studies or problematic practices in oncology today. I have got nothing personal against those particular studies. I'm using them just as representative examples. First, let's begin with the story of olaratumab, a story most of us are aware of, I guess. So this is a drug that was tested in a phase 2 clinical trial for patients with advanced sarcoma in 2016. And the trial showed that this drug improved survival by nearly 1 year. Now, this is something we rarely hear in oncology, improving survival by 1 year. And not just any cancer, but sarcoma, one of the most difficult cancers to treat. But this was a phase 2 trial, with fewer patients, and overall survival was not the primary endpoint of this trial. The primary endpoint was progression-free survival. But nevertheless, when people saw these results, everyone naturally got excited. We said this was unprecedented. This is a wonderful thing. So this drug got approved in many countries based on this data. It got accelerated approval in the US. And I assume as a patient, if you saw these graphs that this drug may improve survival by nearly 1 year, then you'd want to have access to this drug. That's natural. And even countries like England, that is usually taken as a country that does not provide access to newer drugs as easily as other countries do. Even countries like England decided to fund for this drug through the Cancer Drug Fund. But 3 years later, in 2019, we knew that when this drug was tested in a bigger phase 3 confirmatory trial, overall survival benefit was gone. It just vanished. What we saw in phase 2 was a false signal. 12-month OS from phase 2 just disappeared in phase 3. So in these 3 years, in US alone, we had spent $500 million in this drug, and absolutely there was no benefit from it. So the FDA and the European Medicine Agency, they decided to withdraw the approval for this drug. Now, I'm citing this example not as a bad practice. I think this is how a system should function. You see a signal of benefit. You want to give early access to patients. You approve the drug. But then you mandate that there be a confirmatory trial, which should be completed in time. Now, just imagine if this trial was not completed in 2019. If they had never done this trial, this bigger trial, and they were just happy with seeing 1 year of survival benefit in phase 2, we would continue to spend $500 million every year for unseeable future. And if these results were published in 2025 rather than 2019, then there would have been much bigger damage. So this is actually a good example. They mandated that there should be a confirmatory trial. The confirmatory trial was conducted properly in time, just 3 years difference, which is pretty low in oncology. And we found that actually what we saw in phase 2 was a false signal. This drug did not improve survival, and now we are withdrawing the approval. This is not problematic. This is how things should work. But the problem is there are many olaratumabs out there in the market, and nobody is studying them. We published this paper a few months ago in JAMA Internal Medicine about the drugs that had received such conditional approvals. We don't know because a number of these drugs have never been tested in a phase 3 confirmatory trial. A number of these drugs, they were tested in phase 3 confirmatory trial, and they did not improve survival, but they are still on the market. So that's the problem. That's the issue. We don't seem to learn from our mistakes. Just for example, let's talk about the same disease, sarcoma. This is a very recently published paper in Journal of Clinical Oncology. Same tumor type, sarcoma. Now this is a drug called regorafenib. Again, this is a phase 2 trial. We saw that even 1 year of benefit in phase 2 may be a false signal, and it might just disappear in phase 3. But here, the conclusion reads, regorafenib should be considered a treatment option for patients with metastatic osteosarcoma. Should be, not could be, not maybe, not let's test in a phase 3 trial. Just on the basis of a randomized phase 2, we are concluding this should be a treatment option. We are not learning our lessons. Now, what are the results? Let's see what results prompted us to make such a strong conclusion. This is the results from the abstract, and it says median PFS was significantly improved. Okay, there was benefit in median progression-free survival. This is not survival. This is delay in progression by a little less than 2 months. What about survival? It says there was no significant difference in overall survival. There was no difference in survival. This is the abstract. If you actually read the whole paper, then you find that actually the median overall survival with the drug was 11.1 months, And with the placebo was 13.4 months. So actually patients were living longer in the placebo arm than they were doing with the drug. Of course, this is not significant, but the hazard ratio is 1.26. The difference is more than 2 months, and the 95% confidence interval reaches up to 3.13. If 12-month OS benefit, significant OS benefit from phase 2 disappears in phase 3, then can you make a recommendation saying this should be the standard of care based on this data, where the overall survival is actually less with the drug than with the placebo? That's the problem. That's why cheerleading is harmful. We just get excited whenever someone talks of a new drug instead of looking at the underlying data. We just jump to conclusions. One more example, again from this year's ASCO. This was published in New England Journal. Olaparib in metastatic pancreatic cancer. Because I don't want to go after names, and these are just representative examples, some of the names are redacted. So one key opinion leader said, this drug should become the standard of care. Not could, not may, should. Another key opinion leader says, this is a truly remarkable finding. Wow, what a wonderful drug. Someone said, this is really exciting data. And someone even went to say, it is now our duty to search for this mutation, thereby meaning if that mutation is present, we have to use this drug. It is our duty. That means if you fail to do this, you are not fit enough to call yourself an oncologist. It's your duty. Now let's see what the results are that made us say such strong remarks. These are the data. So on the left, we have progression-free survival. So there is some decent improvement in progression-free survival. But if you look at the overall survival on the right, there is absolutely no difference. You can't even say which curve is over the which curve. They are running parallel. They are running, they are collinear. And actually, if you look at the control arm, it says placebo. Why? Because in this trial, what they did was, after a certain number of cycles, they randomized patients to get olaparib, the drug, or placebo. In real practice, that rarely happens because we don't want pancreatic cancer patients not to receive anything. In real practice, these patients keep receiving chemo. But here, after a certain number of cycles, they either got olaparib or they got nothing at all. So this difference in PFS is not that impressive because the control arm patients are not getting anything. And overall survival, which matters the most, has absolutely not improved. Now, when I say this, some people argue that PFS will be meaningful because if there is delay in progression, that means patients are having a better quality of life because otherwise they would have to take chemo. I'll come to the data about that a little later, but no, PFS cannot predict quality of life. That's why it is important to measure quality of life. And to the researchers' credit, they did measure quality of life in this study. They measured quality of life, and the quality of life was maintained in this trial. Now, do you know what quality of life maintained means? It's a very nice way of saying quality of life was not improved. Instead of saying not improved, if you say maintained, it looks nice. So basically, what we're talking about is a drug that does not improve how a patient feels, that does not improve how long a patient lives, but will cost more than $12,000 a month. In Canada, I think it costs around $7,200 Canadian dollars a month, and has some side effects, some of which are substantial. This does not make sense to me. Especially, it does not make sense to me to say that this is truly remarkable and it's our duty to use this drug. So I have been, when I was a trainee, first of all, I used to look at all these big trials and the conclusions from key opinion leaders about these trials. And then when I went to see the actual data, then I started to get frustrated. The data are not supporting what people are saying about the drug. So in 2016, I started to write my own blogs to vent that frustration. And in 2017, when it was like 1 year anniversary of my blog, I wrote about maybe what we need in oncology is not a center for precision medicine or a center for immunotherapy, but what we actually need is a center for sense in oncology. That is what we actually need. And most of the things that I say are actually not smart things. I think the things that I say are pretty obvious things. Patients should live longer, patients should have a better quality of life. These are not extraordinary things, but it amazes me that someone has to say it. Like, why is it not self-evident? Just like this sign on a glass door, like, why should someone put this sign? Because apparently some people need to read it. They can't figure it out themselves. Pull. If it doesn't work, push. If that doesn't work either, maybe we are closed. That someone has to say this baffles me. And it's true in oncology. So when I talked about it, it got a lot of attention, and people started to ask about, this sounds like a nice idea, so what would the functions of such a center be? What would the roles be? What is such a center supposed to do? Then I started to think about it in detail myself, and I think there are a number of things that such a center can help with, and such a center should do. And obviously, I won't have time to go through all of this today, but let me highlight a few important key points. So, first, let's talk about patient and physician education. And there are a number of points under patient and physician education, but first, let's discuss about differentiating hope from hype. This is a very crucial point. There is a very big difference between being hopeful and cheerleading. Now, this was a news that I read in BBC last year, and it says, remarkable therapy beats terminal breast cancer. This is so exciting. What's not to like about it? It's a remarkable therapy. It beats cancer, and not just any cancer, terminal cancer. Wow. And naturally, I got interested, and I wanted to find what study supported this headline. So this was the study that made news. And actually, this was not only in BBC, this was all over the media. So there is something called altmetric score, if you know about it. This gives a measure of how much online attention a certain study has gained. And if a certain study has an altmetric score of more than 100, that's a pretty big deal. If it is more than 1,000, that's humongous. That's extraordinary. And this study has an altmetric score of 2,000, nearly 2,000. It was covered by 120 news outlets. So this should be a pretty remarkable study, as remarkable as the headline is. But if you look at this study, this is actually the story of a patient, not even patients, a patient, one patient, that led to this big headline. If you were a patient and you read the headline, you would naturally want this drug. But this is an experimental therapy that was tested in one patient. And one patient had this response, remarkable response. I don't know how many patients we tested on. One more example, now from prostate cancer. This was in Lancet 3-4 years ago. A very exotic sounding drug, padaliporfin vascular targeted photodynamic therapy. The name itself sounds like this drug is going to be wonderful. And this was tested against active surveillance. Now, active surveillance means you observe, you don't intervene. You just observe and see what happens to the patient. And if needed, you intervene. This study also created lots of headlines. One news said, this drug is a leap forward for prostate cancer treatment. Another headline goes, this is a game changer for men. Wow, let's look at the game that it has changed. If you look at the underlying data that led to this leap forward game changer news, this is the data for efficacy. So here is the active surveillance patients, 207 patients that did not receive the drug, that did not receive anything at all. And here is that exotic sounding drug. If you look at number of patients who developed metastasis or number of patients who died because of prostate cancer, it's 0, even if you don't do anything. even if patients did not receive any treatment, even if they received, they were just observed, nobody developed meds, nobody died of cancer. How can you improve on a mortality rate of 0? How can you improve 0? Nobody died. There was no game to change. How can it be a game changer? So these were patients that should not have been treated, and now we are thinking about a fancy, expensive drug that cannot improve because the baseline itself is 0. But let's look at the altmetric score, the online attention this study received. It had an altmetric score of 1350. That's so huge. Just to put into perspective, here is one more study, which is a pretty nice study. What they did was they asked patients to put in their symptoms, what we call patient-reported outcomes, using an online tool, and they monitored that online recording of patient-reported outcomes. And this simple act of recording patient-reported symptoms and acting upon it improved survival in lung cancer patients. And this study had an altmetric score of only 59. Only one news outlet picked it, and that was my own blog. Why does this happen? By the way, this padalipophine, it did not get any approval from, I don't know of any agency that approved this drug. But why are we so excited about every new thing? This drug was derived from bacteria found at the bottom of the ocean and is activated in prostate by using laser beams. Is that the reason? It sounds so sexy. It was derived from the bottom of the ocean. Wow. And is activated by laser beams. But did patients actually have any benefit? No. That's the only thing that should matter. So we see that there is a huge role of media in how they present the studies and how they can educate the patients versus mislead the patients. This news says, new drug wakes up immune system to fight one of the deadliest cancers. A certain drug called IMM101 has extended lives of people with pancreatic cancer and appears to have no side effects. Wow. Extends lives, has no side effects. Too good to be true. Of course, it's false. It goes on to say, this is considered groundbreaking. Now, it said extended lives is groundbreaking, but a couple of paragraphs later, the same news says the overall survival benefit, however, was not significant. How does that make sense? You just said it extends lives, and now you are saying there was no benefit in survival. What does extend lives means? So this is the crux of the problem, not only with media, with all of us in the oncology community. We have a bias towards cheerleading every new intervention, towards thinking any new drug is a wonderful drug without looking at the underlying data. That is a huge problem. And that is on one hand. On the other hand, we are not conscious about avoiding treatments when it is not essential. That is also a very crucial skill that a clinician must have, or that a patient should be aware of. So we never talk about avoiding things. We are always focused on doing things. What is the new thing that we can do for this cancer? What about, maybe this intervention is harmful, maybe we should not do this. So that's why I thought we need a campaign called Avoiding Wisely. We have Choosing Wisely campaigns in a number of countries, including Canada, and I'm a fan of Choosing Wisely. I am. But I think one issue with Choosing Wisely is we don't go into a specific drug and say we should not use this drug in this particular setting. We try to make more of a blanket recommendation. So in oncology, I wanted to make a list of all the low-value practices that don't benefit patients and that we can avoid. I wrote this paper in 2017, and I made a list of a number of practices, a number of drugs in oncology, a specific drug in a specific setting that we should not be using. And speaking of avoiding wisely, one issue that I want to discuss in a little detail is treating cancer patients towards the end of life. Now, this is a very delicate issue and sometimes controversial. But I think as an oncology community, all of us, clinicians, policymakers, patients, agree that no cancer patient should suffer the tragedy of having to spend the last few months of their lives getting chemo, suffering the side effects of chemo, rushing to hospitals, rushing to emergency departments. A peaceful life-death transition is a very important goal for cancer patients. But for some reason, we always try to overdo things. We always try to push chemo until the very end of life. Studies have consistently shown that many cancer patients still receive this highly toxic therapy with questionable benefits until the very last day of their life. The number of patients who actually get chemo in the last 30 days of their life is not small. A substantial fraction of patients are getting that. And we know that it's going to be of no benefit. And if it has any effect, it's going to be only side effects. But still, we keep doing that. And there are a number of reasons for this, which I try to explore in this paper. But one important factor is also the way we describe cancer. We try to describe the journey of a cancer patient as a battle, as a war, as a fight. He is fighting against cancer. Someone is going to win this war on cancer. There is a battle against cancer. These metaphors are unproductive. And actually, I think it takes more bravery to sit with the patient towards the end of life and discuss about not giving for the chemo and focusing on quality of life than it takes to just say, oh, yeah, your tumor has progressed, but let's try a new drug. It's pretty easy to say, let's try this new drug. It's very difficult, and it takes a lot of bravery to say, maybe it's time to discuss or to focus more on the quality of time that you have left. And actually, I came across an obituary of a cancer patient whom I don't know, but I just read that online, and I found it very touching. And I have a link for that here. I think you can read the whole obituary. It's very nice. But this is the paragraph that actually touched me a lot. Tim led a good life and had a peaceful death, but the transition was nasty. And for the record, he did not lose his battle with cancer. When he died, the cancer died. So technically, it was a tie. He was ready to meet his maker. We are just not sure the maker is ready to meet Tim. Good luck, God. Anyways, now coming back to the core issue of education. Education to patients, education to physicians. And an important part of that is the language that we use. And sometimes we misunderstand what the particular term means. Like this doctor says, we did a brain scan and we couldn't find anything. And the patient says, what? I have no brain? And the family thinks, oh, we knew this all along. For example, we use a number of superlative terms to describe cancer drugs. And in this paper, the researchers looked at the superlative terms that were used to describe cancer drugs, like breakthrough, game changer, miracle, cure, home run, and whatever. And when they looked at those drugs, actually half of them had not even received approval. And these were the terms we were using to describe such drugs that were not even approved. So it's as if if a drug is described using these terms, that drug is more likely to be a very lousy drug. You know this guy? He's an English soccer player. His name is Danny Drinkwater, and apparently he did not drink water. He drank alcohol, and he was charged with drink driving. I find it very hilarious because I used to follow him, and whenever I look these cancer drugs that are described as breakthroughs, I remember this incident. It's like a misleading name. So getting back to our agenda of educating patients, because we need empowered patients, and patients can be empowered only when patients can understand these details of clinical research, trials, spin, and hype. And that's what I think, if we ever have a Center for Sense in Oncology, should focus on. Because once we educate patients, once we empower them, they will know the difference between a clinical trial that is designed for their benefit versus a clinical trial that does not solve patient agenda at all and is designed for some other purpose. Now, let's go into some of the specifics of this. For example, a trial that is designed from the outset to test clinically irrelevant marginal differences. For example, there was this AGO-12 trial published in Lancet a number of years ago. And the conclusion is that this drug significantly increases progression-free survival for women with advanced ovarian cancer. Sounds good. Significantly increases progression-free survival for women with advanced ovarian cancer. But let's look at the margin of difference. By how much did it improve? If you look at that, actually it improved PFS by only 18 days. Only 18 days. And this is not survival. This is progression-free survival, a surrogate mark. Only 18 days. But that statement technically is not incorrect, because this difference was indeed significant. It was less than 0. The p-value was less than 0.05. Why does this happen? Because we enrolled more than 1,350 patients in this trial. If you enroll thousands of patients, then any difference, even a difference of 1 day, is going to turn out to be significant. That's what we call as overpowering a trial, enrolling more patients than needed, so that any difference will look significant. But is it clinically meaningful? No, absolutely not. One more example of a trial that does not solve patient agenda is a trial that ignores patient-related outcomes or quality of life. Now, if there is a trial of a cancer drug, and that trial says we are not going to record quality of life, we are not going to record how patients are going to feel when using this drug, then you would be very, very skeptical about that trial. Why would they not want to know how I'm feeling? And we actually did a study on this. We published this last year. We looked at 352 phase 3 randomized controlled trials of cancer drugs, and we found that 50% of them, they do not include quality of life as an endpoint. They did not bother to know whether patients felt better or worse with the drug. And of the 50% that did include this endpoint, 25% of them, they did not report quality of life. That means these trials collected quality of life information, but decided not to publish it. So altogether, this was more than 125,000 patients who were enrolled in these trials. So we lack quality of life information from more than 125,000 patients. This is such a huge waste of resources. And whenever I present this, some people say, why do we need quality of life data? We have data on progression-free survival. So if progression-free survival is improved, that automatically means quality of life has improved. I said, okay, let me test this. So I checked that, and what we found was the correlation between progression-free survival and improvement in quality of life was very weak. That means progression-free survival cannot predict quality of life. You have to measure quality of life. You cannot predict it using other tools. You have to measure it specifically. One more example of a trial that does not solve patient agenda is a trial that is conducted without rationale. For example, we conduct a phase 3 trial, even though the phase 2 trial of the same drug was unsuccessful. You might think this is crazy, this doesn't happen. I thought so too until I did this study. And we found that 40% of the negative phase 3 trials were conducted without any phase 2 evidence. Shockingly, 14% of them were conducted despite a negative phase 2. A drug failed in phase 2, but still we decided to take it to a phase 3 trial. Now there comes the responsibility of the ethics board committee members. Why would a patient want to get enrolled into a phase 3 trial of a drug that has already failed in phase 2? One more example, a trial that uses non-inferiority design inappropriately. So non-inferiority design trials are a little special trials in that the usual trials, the standard trials, what they test is, we have a certain drug already, whether this new drug is better than the drug that we already have. That's the usual trial. But non-inferiority trial, what it tests is, we have a certain drug, whether this new drug is not worse than the drug that we already have. Now you might think, why would somebody want to test it? But there are some valid reasons. For example, if the new drug is cheaper than the drug that we already have, or if the new drug is oral, but the drug that we already have is given by injection, then that's a huge comfort to the patient. If the new drug has better quality of life, there are some valid justifications. But if those extra benefits, compensatory benefits are not there, then there is no point in testing whether this drug is not worse or not. We have to test whether this drug is better or not. We want to improve outcomes. But in this research, this was published less than a week ago in JAMA Open. We looked at non-inferiority design cancer drug clinical trials, and we found that 40% of them had no justification. That means they were not oral versus injectable. They were not better quality of life versus worse quality of life. There was no justification to test them in a non-inferiority fashion, but still they were using non-inferiority fashion. Now you'd think, why would someone want to do that? Because it's much easier to show that a drug is non-inferior than it is to show that a drug is superior. And here comes the catch, because the definition of non-inferiority, the definition of how worse is worse, there is no definition. So the researchers can just agree upon any definition they want. And in this study, we found that that definition ranged up to the hazard ratio, 95% confidence interval limit of 1.33. What that means is, the researchers agreed that up to 33% increase in mortality was okay. But my point is, did we ask patient up to what percent increase in mortality was okay? No, we did not. So how can we say, what if someone says, no, up to 45% increase in mortality is okay? Or someone might say, okay, let's double the risk of mortality, that is okay. So where does it stop? And how do we come to that consensus? Only patients can decide up to what percent increase in mortality is okay. So all these issues with non-patient-centric clinical trial designs of cancer drugs, I tried to summarize it in this chapter I wrote for the ASCO book this year. And at the end of this chapter, I tried to make a list of the key questions that a patient should consider before enrolling into a clinical trial. So most of these questions will have answers in the informed consent forms, of course, but these are the questions that patients should be specifically aware of. Because we know that most informed consent forms, they don't inform patients. And at the end of this list of questions, you'll see that I have a question that says, what are the plans for publishing this trial? Because publication of a clinical trial is a big deal, because some trials don't get published at all. So you enroll hundreds of patients, and you don't get results that you would like to see, and then you decide not to publish it. That's a huge disservice to the patient. And the other thing is, when you publish a trial, usually people want to put spin on the trial results to make the drug look better than it actually is. And this spinning you can see very frequently when describing toxicities or side effects from a cancer drug. So I published this research last year in BMJ, in which I looked at cancer drug trials that used these downplaying terms to describe the harms from the cancer drugs. Like they were saying, for example, the side effects from this drug was acceptable. What does that mean? Acceptable to whom? This drug's side effects are manageable. This is a feasible treatment. It has a favorable toxicity profile. This drug is well tolerated. And they even say, number of times, this drug is safe. Safe. And then you go and look at the adverse effect profile, and there are a number of patients who died due to side effects from the drug. How can you say it is safe? And when I looked at these trials, I found that for the trials that use these terms to describe side effects, actually, the incidence of severe side effects, serious side effects, and fatal, life-taking side effects were actually higher with the drug than in the control arm. 77% of the trials had higher severe side effects, 84% of the trials had higher serious adverse events, and death in 66% of the trial with the drug compared to the control arm. Now, let's change gears a little bit. And you might think that this problem of cheerleading, not using common sense, is unique to high-income countries, but I'll tell you that, no, it's not. This problem is very prevalent even in low and middle-income countries. So a common sense approach to oncology is needed even for low and middle-income countries. I'll give you some examples. When I read this news in BMJ about India planning to launch a national cancer screening program, I was a little excited. But then I went and read that they said there will be mandatory screening for oral, breast, and cervical cancer in people over the age of 30. And then I was taken aback. Mandatory screening in people over the age of 30. Why would you want to do that? Even in high-income countries, for example, we still debate whether mammography is a good screening tool or not for women. But I think at least there is no debate that a girl of age 32 needs mammographic screening. And they say it's a mandatory screening. We're trying to, low and middle income countries are trying to copy-paste high-income countries, exaggerating the mistakes that they have made. And it's not only about screening. Look at this. Some people are worried about how we can implement precision oncology in Africa. When in reality, to be honest, precision oncology has not delivered even in high-income countries. There are some exceptions. There are some wonderful precision oncology drugs. But the genomic-based sequencing and using targeted drugs based on the findings of the NGS screening, this has not lived to its expectation. This is a pretty new study in Annals of Oncology. I think it has been less than a month. And in this study, and this is from Europe, high-income setting. In this study, they did NGS to cancer patients, and then they sought the opinion of molecular tumor board experts, and then they used the mass-targeted therapy for that particular mutation. Even then, only 6% of patients actually got mass therapy, and the overall response rate was 0.9%, not even 1. But we are more worried because people in Africa, they don't have access to this wonderful thing. When in fact, this is the reality. US dogs have better access to radiotherapy than Nigerian people. It pains me, not because I'm against dogs, I love dogs, but because my fellow human beings who do not have access to life-saving treatment, this is not life-prolonging like other drugs, this is life-saving radiotherapy. They don't have access to this. But we are worried about they not having access to precision oncology. Let's look at these two articles side by side. On the left is a study from India, not from a high-income country, about Watson for oncology, which is artificial intelligence, using artificial intelligence in oncology care. While the fact in most low-income countries is that there is no access to even surgery, radiotherapy, or pathology services, interventions that actually save lives. So we should not make the mistake of copy-pasting what high-income countries are doing in low and middle-income countries. So I wrote this paper in Lancet Oncology last year because this contrast really touched me. And I asked, does global oncology need artificial intelligence? And my conclusion was, no, low and middle-income countries need more common sense than they need artificial intelligence. So it's all a question of prioritization, you know. So prioritization is the most common sense approach to solving any problem. So when your husband has been hit by a bus, the first question you ask is whether he's alive. Similarly, in cancer care, first let's go global before going to the moon. This I published in Lancet Oncology called Cancer Groundset. This was in response to the Cancer Moonset. And the basic idea is at a fraction of the cost of the moonset, if we use that fraction of the cost, then we can implement the strategies globally that we already know will work to save lives, and we'll be saving more lives than what moonset is ever going to achieve. This is the graph of mortality due to cervical cancer across the world. The redder the country is, the higher is the mortality due to cervical cancer. Now in 2019, I think nobody should die of cervical cancer. Australia and New Zealand, they have shown that this is one particular variety of cancer that we can actually eliminate. We can talk about elimination. We have effective screening tool, we have effective vaccinations. But more than half of the world is still red. They don't need precision oncology. Immunotherapy is not going to save them. What pains me is when I talk with my colleagues from low-income countries, sometimes I find my colleagues worried that, Bishal, in our country, we don't have Avastin for advanced cervical cancer. That baffles me. Avastin is a drug that improves median survival of metastatic cervical cancer by nearly 3 months. My point is, why should anyone have metastatic cervical cancer? At a fraction of that cost, if we focused our resources on these strategies that will help us to eliminate cancer, then that is a thing that you should be more worried about. You should be asking, why don't we have HPV vaccinations in our country, rather than asking, why don't we have Avastin in our country? So let's go to the crux of today's talk. Why is cheerleading so common, but common sense so uncommon in oncology? The first answer that comes to my mind is financial incentive. Because if you look at it, everybody in the healthcare ecosystem benefits from cheerleading, from the consequences of cheerleading, hype, overtreatment, overdiagnosis, giving drugs to everyone. Everybody benefits. Doctors, hospitals, insurance companies, and most importantly, the drug manufacturers. Who does not benefit is patients. They are the only one. But at the center of healthcare ecosystem should be patients. Patient benefit is what should matter the most. All other things should be secondary. Healthcare system should exist to take care of the patient's needs. It should not be the other way around. People sometimes do crazy things when financial incentive is at stake. I read this article in New York Times this March. There is a new luxury retreat in the west coast of the US that caters to elderly workers in tech. And because they cater to elderly workers, they need as many clients as possible, so they defined elderly as the age of 30 and up. So I'm an elderly. Now it's time for me to retire. That's why I can say whatever I want, because I'm retiring soon. But there are other reasons as well, beyond financial incentives. I think the problem is cheerleading has become mainstream. It's much easier to go with the tide than to go against it. If you look at all the leadership, all the key opinion leaders, people in positions of power in the field of oncology, you look at them, and most of them cheerlead. Most of them get pretty excited whenever there is any new drug coming out. They are saying wonderful, flowery things about these new interventions. And naturally, as a young researcher, as a young doctor, you would want to be one day in that place, and you would want to follow them. Why would you want to risk your career by saying, by going against mainstream? What's the benefit there for you? None. And then there is the issue of optimism bias. We want to believe that we are doing good for the patient. We want to believe that this drug is going to help the patient. It gives us a sense of fulfillment to keep doing things rather than withdrawing things. And there are plenty of opportunities to discuss about how wonderful a certain drug is. There are CMEs, there are industry-sponsored lecture events, but there are very few opportunities to discuss about how to critically appraise the literature, how to look at the evidence, how to form an informed opinion. There are very few opportunities. And then there is public hype, of course. Just contrast the news coverage, how different it will be if someone says, oh, this is a wonderful drug, versus if someone says, there is a lot of nuance in the data. It might help some, but A person that I really admire is Dr. Otis Brawley. He was Chief Medical Officer at the American Cancer Society. And he puts it very succinctly. He says, I'm starting to hear more and more that we are better than I think we really are. And the problem with cheerleading is that we are starting to believe our own hype. And it will have deadly consequences. So where is the common sense camp? where have wise people gone? There are no institutions. There are no, like there is Center for Precision Oncology. There is no Center for Commonsense. There is no institution. There is no conference for critical appraisal. There is no conference for acting wisely, avoiding wisely. There is no society of common sense people in oncology. There is no journal. There is no initiative. Nobody funds such research. Nobody gives grants for such research. But these are subsidiary things. The primary thing is there is no inspiration for younger generation of doctors, for younger generation of researchers to work towards bringing common sense back into oncology. That is a big void. There is no one to look up to and say, I want to be like this person. And because nobody else is going to support this, it should be governments and public's priority. Because again, the key question is, if we all start to cheerlead, who receives the biggest harm? Patients. Therefore, it should be governments and public's priority. Because industry or other financial institutions are never going to support reducing care or support critical appraisal of evidence and teach doctors how to make wise decisions. And I'm not blaming them because that's how the ecosystem works. What I want to stress is somebody has to support the common sense camp to bring balance, because right now it's too one-sided. So I'd like to conclude with this. We need common sense in oncology. We need it more so today than ever before. And we need it not only for high-income countries, we need it globally. This is an issue that should concern every country in the world. Thank you very much for listening to me.
Well, thank you very much, Dr. Gyawali. We now have some time for questions, and we can try to alternate between questions online and in person. If participants in the room in Ottawa, I just ask that you turn on your microphone, speak clearly, say your name and what organization you represent, and then also turn off your microphone when you're finished, so others, you can keep yours on, but so everyone can have a chance. But maybe I'll open it up first in person here in Ottawa. Any questions? You were first, Brian, so go ahead.
Yes. Hi, Brian O'Rourke from CADTH. Your talk about common sense in oncology, or the need for an institution of common sense in oncology, sounds like CADTH or the HCA community, actually, so I would put a plug in for that. But I was more interested to hear two things in particular. One, PFS, should we just eliminate that as an outcome? Mm-hmm. And secondly, you didn't talk about tumor agnostics. Okay. I'd love to hear your thoughts on that.
Thank you. These are great questions. Now, about PFS and the value of PFS as an endpoint, it's a surrogate endpoint. And it will have value if we can validate it as a valid surrogate. So there have been a number of correlation studies. And in certain tumor types, it does have a strong correlation with overall survival. So in that case, it's okay to use the surrogate endpoints because it has a strong correlation with overall survival. But in most tumor types, the correlation is pretty weak. So in that case, a benefit in PFS will not have as much meaning because, and the way we define PFS is also very arbitrary. We call progression as increase in tumor size by more than 20%. So increase in tumor size by 19%, not progression. 20.5% becomes progression. But what actually will matter is when that tumor size increased by more than 20%, did patient start to have a worse quality of life? So we need to test whether PFS has a good correlation with quality of life or not, which we did last year, and we found that actually that correlation is pretty weak. And we need to correlate whether benefit in PFS will translate to benefit in OS or not. And in some tumor types, it does. In most tumor types, it does not. So, and the other thing about using PFS as an endpoint is, why would one want to use PFS as an endpoint in a clinical trial? It is supposedly to reduce the duration of the trial. And I think a research published a couple of months ago showed that saving in time is, I forgot the exact number, but it should be somewhere between 6 to 12 months. So it's not more than 1 year. The time that we save by using PFS as an endpoint in clinical trials as opposed to using overall survival. But you have to balance that saving in 1 year with 100 of years after approval that we have to live in uncertainty about whether that drug actually improved outcomes or not. So that's my thought about the problem with using PFS as an endpoint. And like sometimes we did this research last year. Sometimes using PFS is actually detrimental even to industry. For example, we did this analysis for immunotherapy drugs. And for immunotherapy drugs, we found that actually the benefit in overall survival will be larger than the benefit in progression-free survival. So there are a number of examples where there is no benefit in PFS, but the drug went on to improve OS. So if they had never measured OS, and they had measured PFS only, and said this is our primary endpoint, then those drugs would have been considered to be failure, when in fact those drugs did improve overall survival. And the other question about tumor agnostic approval is that, I saw those data, and I agree with the FDA's decision to give it accelerated approval. So it, I agree with the decision to give tumor agnostic drugs accelerated approval, but I do not agree with the decision to give these drugs full approval. One of the pitfalls is that when I read that New England paper, for example, larotrectinib, which got tumor agnostic approval for NTRK gene, you see that when it gets approval across all tumor types. But when you look at the trial, you see that, for example, there is only one patient from appendix cancer. There is only 1 or 2 patients who had breast cancer. And you see at the overall response rate, which looks like 60%, but the response rate in patients with breast or appendiceal cancer is either 0 or 10. Like, we tested only one patient, and that patient did not respond. So if we say this has to be approved across all tumor types, what we are saying is all patients with breast cancer and appendiceal cancer and all those cancers that did not benefit in that trial should also be tested for the mutation and should be given the drug if they are tested positive. Whereas the evidence that we have says these particular patients, they don't respond at all. Majority of the patients were had salivary gland tumors. So I'm of course comfortable with using larotrectinib for salivary gland tumor patients who have NTRK fusion. But I'm not supportive of using this for patient with appendiceal cancer who has NTRK fusion, or I'm not supportive of checking for NTRK fusion in patients with appendiceal cancer. Thank you.
Okay, great. I think we'll take one more from in person, and then we have a number online as well. So, Shang, I think you were first. Or maybe we'll, because this is a CADTH staff member, maybe we'll have one of our guests first and then switch up.
Well, I have a comment, not a question. Some of the examples in the beginning you presented regarding study that there's no question, I agree with you, it's not a good example that regarding survival, number of samples, how they concluded or exaggerated their outcome. We should also mention there are many good studies and clinical trial. First of all, most of these I notice is phase 1 or phase 2. Usually the outcome for approval based on phase 1, 2, 3, when the large number of samples is studied. And I'm a myeloma patient, and the chance of survival for myeloma patient 10 years ago was only 2 years. Because of new drugs, now the patient is incurable cancer. Right now, the average survival is 10 years. And already what I want to fair comparison of both sides. Without clinical trial, access to this data is impossible for the patient. And I don't want people walk out of here with the perception especially with CADTH, that already difficult to approve drug, orphan drug for Canadian patient, and work with that is studies. Real life data later on with a good drug also is created, and they can do further approval later. But for cancer patients to survive, they need access to this data, and it should be represented from both sides of. There's no question publication, people publish nonsense. There's no question clinical trials, some of them is. It's a judgment how to use on this data and how much information to gather, but not to make it impossible for cancer patients to have access to these life-saving drugs. And one thing I agree with you, definitely, it should be patient-focused, and definitely the quality life should be center of any clinical trial, and input of patient is very important. Thank you.
Thank you, ma'am. I definitely agree with you. And my point is, I agree with you in that patients need access to cancer drugs early. My only agenda is, I think patients need access to good cancer drugs early. They don't need access to any or harmful cancer drugs early. For example, I'm not a myeloma expert. I was trained only in solid tumors, so I don't know about hematological cancers. But I know that, for example, the immune checkpoint inhibitors, nivolumab and pembrolizumab, they were tested in multiple myeloma without having a solid phase 2. They were directly tested in phase 3. And what happened was, patients receiving these drugs, they had higher mortality than the control arm, so the FDA had to stop the trial prematurely. They had to stop it in the middle. So, yeah, my only point is that cancer patients definitely need access to cancer drugs as early as possible, but we need to make sure that when they're having access to cancer drugs, they're having access to good cancer drugs that is actually helping them, rather than cancer drugs that, even 10 years after approval, nobody knows whether it is doing any good or not.
I know about that study you mentioned. The mortality was higher. This is a particular drug used for other blood cancer. They gave it to myeloma patient. Later on, they realized, the clinical trials at research level, they realized certain mutation actually only respond to that. And if the patient doesn't have, because patients are very heterogeneous, don't have that mutation, then the mortality went for that group. They learned from that something. So the drug is still useful. That's why they brought it back to the clinical trial. Majority of drug for that new, so-called new drug, it's been already 5-6 years approved. A lot of data generated for myeloma, and we are behind in Canada to get funding and save life.
Thanks very much. I think we'll move on to a couple questions online as well. If I can just maybe get you to turn your microphone off. Thank you very much. And just to say that I think Dr. Gyawali is able to stick around for a few minutes after, just for there's a short coffee tea reception. So I think we are going to run out of time a bit for questions, because we have a number coming in online as well, and I want to share the time. So maybe I'll hand it over to Amy to share one of the online questions.
Thank you. So the first question here is, there are 5 oncology drugs in Canada that were conditionally approved more than 10 years ago that have not fulfilled their conditions. Do you have any comments? And I might add, more broadly speaking, do you think that conditional approvals and conditional reimbursements are the right approach to uncertain data?
Yeah, I think conditional approval is a right approach, and I actually support conditional approval and what they call accelerated approval in the US. And that is, I think, a very good balance between providing early access to drugs and confirming that the drug actually works. Because when you give conditional approval, what you say is, we have only preliminary data. We have only data based on surrogate endpoints like PFS, but we are going to approve it anyway. But the drug has to be tested in a proper phase 3 trial using overall survival endpoint later, and you have to prove that this drug is actually useful. So I think that's a very good midway between ensuring early access versus ensuring that the drug is actually a good drug. But the problem is, are we able to execute that mandate well? As we looked at this study for the accelerated approval of cancer drugs in US, we saw that there are a number of cancer drugs that are in the market many years after accelerated approval and without confirmatory trial. So just like the example of olaratumab, if olaratumab had not been tested in a confirmatory trial, then we would still be using it. We would be using a drug that was useless for cancer patients. So there are many other drugs that, as you mentioned, like in Canada, got conditional approval. But like in this table, these drugs, they fulfilled their confirmatory trial requirement. And in the confirmatory trial, they showed that it did not improve outcomes, but they are still in the market. If that is the case, then there is no point in giving conditional approval.
Great. And another online question. You had mentioned there are no conferences or grants for critical appraisal of new cancer drugs, as opposed to the existing great emphasis placed on cheerleading new drugs. Do you think a shift toward the more critical view would best happen with the creation of new publications or institutions, or can it be a set of new practices or approaches that can be integrated into the existing system? This is from Brian O'Shea, PMPRB.
Thank you. That's a very good question. And I think it can happen both ways simultaneously. There is no reason why one should exclude the other possibility. I think we need to start, as I mentioned in my talk, I think we need to start to inspire the younger generation who still have a very open heart and open mind. We need to inculcate the skills of critical appraisal, having an unbiased eye, and working for patient benefit instead of just jumping into the bandwagon. And at the same time, if we also had some dedicated institutions, conferences, journals to support this practice, then these new young leaders would have a place to call home and would have a society to call their family.
Okay, I know we have a number of questions that have come up in person and online. I think what I would suggest is that we sort of move this to the reception stage. And then the questions that came in online, maybe what I would propose is that I share those with you, Dr. Gyawali, and
Yeah.
since you're such an active tweeter, maybe you can share your responses to them. Maybe we can tweet them out from the CADTH account too, so everyone can see them. And with the hashtag, and then maybe you can give a response to those as well. If that's
Sounds like a good
possible.
idea. Thank you.
And if you're not able to speak directly with Dr. Gyawali after the talk, then certainly share, and we can tweet those as well.
Thank you.
So with that, I'd like you to join me once again in thanking Dr. Gyawali for coming here today and making the trek from Kingston and sharing with us.
Thank you.